I have the pleasure and honor to invite Dr. Arab from Kingdom of Saudi Arabia. He is the Director of Women and Fetal Health Program at Dr. Arab Medical Hospital. Dr. Arab will address us about abnormal uterine bleeding management, a giant step forward, a Saudi flag. Dr. Arab, please.
Bismillah ar-Rahman ar-Rahim. I'd like to thank Professor Gamal, Professor Amr for their kind invitation. Thank you, Mr. Chairman, for the kind introduction. Well, we're going to just switch a little bit of our attention from infertility to one of the causative problems of infertility in general, which is the abnormal uterine bleeding. And the reason I'm presenting it here because we just submitted our Saudi guidelines for publication, again, the management of IUB. To understand this, actually, just a simple introduction about the definitions, we all know about it, but I never understood AUB till this FIGO classification came out. We used to talk about polymenorrhea, menorrhagia, oligomenorrhea, and all this, which is really making no sense. But once we got this Palm and Coin classification, at least we have now an understanding of a problem that really lasted for long. So the thing is they differentiated the structural from the non-structural or dysfunctional causes. And here we can see that these structural things, if we can exclude them at once, so this is how we approach. We had in our guidelines about 9 sections, each one including each one of those letters in order to approach. So first of all, which is the simplest thing, is to exclude the structural problems. We know very well the imaging modalities that we have. First thing first, which is really the ultrasound that is coming handy. You can do it by yourself in the office. Of course, there are many like terminologies being involved, also many techniques and approach. For example, we have the International Endometrial Tumor Analysis terminology, IETA, which is mainly to look for hyperplasia and looking at the vessels and the thickness and description of the endometrium itself. Then came also the morphological uterus sonographic assessment, the MUSA classification, which is really mainly for the fibroids, as well as the adenomyosis. So this is one way of looking at the myometrium, and this is something can be also looked at, especially if you're talking about the intracavitary problems. The sonohysterography is beautifully working to show you the polyps and maybe some mucosal fibroids. But above all, actually, MRI can come really handy in order to differentiate all these pathologies and to get to the final diagnosis. Not to mention the hysteroscopy. Really, it's important that hysteroscopy now is coming as an office hysteroscopy, and I'm really promoting this concept because this can be part of our management, as you can see later. Usually, we reserve it to the suspicious conditions. However, I mean, if you have it at hand in the office, why not to go ahead and use it? Now, the AUB problem in general, I see it really materialize from 3 important issues that can be looked at. Number one, the patient normalization of the heavy menstrual period. That's why the patients really can be suffering for some time. And then a doctor's oversight, which is really something that we have to blame ourselves with. And number 3, the inconsistent management. Well, with this inconsistent strategies, now we have to modify it or unify it at least. And to start with, I want to talk about the woman, awareness. And this is something very important because you can see here, 50% of women think that heavy menstrual period is a normal thing. Most of them actually don't even want to go to see a doctor. What will happen? They just keep bleeding, and they and some of them actually may take sometimes a year or 2 in order to go and see a doctor. Even when they see the doctor, unfortunately, some of us, they don't give her the right answer or the right solution. Sometimes maybe because of there is no time in the clinic, and that's why they miss the boat in situations up to 40% of these cases. Now, we all know that whenever there is a bleed, there is a loss, there will be anemia. And we can see here, it has been 2/3 actually of women with heaviest period, they have a hemoglobin of less than 12. And for that reason, they have been losing actually iron, which is about 5 to 6 times the normal. For this reason, one of the recommendations now in our guidelines is to do the CBC and ferritin as a requirement for any patients coming with abdominal uterine bleeding. And of course, the patient symptoms, she doesn't tell you I have a fibroid or a polyp, but she may come to you suffering from hair loss, from just fatigue. But these are not symptoms of AUB, these are symptoms of anemia. So there is an element here that can be missed over the time. We gynecologists really get very upheaved with all these different algorithm or flow charts, the management of AUB. Give Mirena or give progesterone or give tablets, or do a myomectomy or do hysteroscopy. Well, unfortunately, we get really occupied with all these as a gynecologist and forget about the anemia itself. So here, my advice actually is to remove this blinder. I mean, remember that this is a patient is also bleeding and she is anemic, so do the anemia testing. This is a very interesting study that I came across, published in 2014. Now, patients with heavy menstrual bleeding, they did very detrimental 2 treatments. Some group, they give them hysterectomy, and the other group, they give them what? Mirena. But they never managed the anemia itself. What happened? The bleeding stopped, that's fine. But patients took about 5 years in order to correct their anemia, to have their ferritin and their hemoglobin back to normal. 5 years. So this shows you these patients have been having all these troubles during for 5 years. So lastly, with the inconsistent clinical strategies, of course, patients were having the dilemma of diagnosis, we have the dilemma of how to treat, and also the thing that patients like what they call the shopping. They go from one doctor to the other and they never reach any solution. So what we came up with actually in our guidelines is that to use what we call the one-stop approach. Okay? Now, to do this, we have to think first about the 9 causes of AUB. So first of all, keep that in mind. We have 9 things that to think about. And what do? You do a tattoo. All right? The first T is for transvaginal ultrasound. You do that in the office. A for anemia treatment. So immediately you do the CBC and ferritin and manage that in the office. T to transfer services. And here sometimes if you have a young girl and her teenagers and she's having this anemia, heavy periods, more likely she might have really von Willebrand disease. So this way you have to transfer her to hematologist. And then you, for the O, you use the office biopsy. If you have an older patient in her late 40s or in the 50s or postmenopausal, maybe the appropriate thing to do is just do the papel testing. And of course, you do the office hysteroscopy if you have it in your office. And I'm encouraging now my young trainees to do more hysteroscopies in order to have this. And we have now offices in many of the clinics in Saudi. So tattoo, remember this thing. You just do these 5 things, and you're gonna reach the, once you have ruled other things, you're gonna have a diagnosis of AUBO. So that's what the FIGU want to tell us. Whenever you have a patient with abnormal uterine bleeding, tell me, is she AUB M or AUBA according to the pathology. Now here, if you do this tattoo, then more likely you're gonna have a diagnosis of AUBO if we ruled out the other stuff. So AUBO is a diagnosis of exclusion, because this is of an ovarian dysfunction and also seen very common in young age and as well as in the near menopausal age. Now, regarding the how this really problem arise. Usually we have two types of AUBO, either the anovulatory or the ovulatory, which is very simple, because the anovulatory is that where we have no progesterone, so this is an imposed estrogen, and it can have an either irregular heavy or irregular light. And heaviness and of the flow itself depends on the amount of estrogen. Lots of estrogen, that means we'll be having lots of bleeding, and of course little estrogen will have less bleeding. While for the ovulatory, usually you have what we call the defect within the endometrium itself. It's not actually the estrogen or the hormonal part. So here, this can be mixed with the AUBE. The AUBE, they related to the endometrial problems. So then there you have also endometrial pathology. And here I can show you how the estrogen factor really causing this breakthrough bleeding. When you have an unopposed estrogen, what will have an outgrowth of the endometrial cells, which is really, if it outgrows of its blood supply, it will slough away, and is according to amount of growth of cells, is to reflected on the amount of bleeding this woman has, either spotting or heavy bleeding, and this is really illustrated that way. And that's why, of course, if a younger woman, she's more likely to have, more bleeding because of the high estrogen. Now, when we talk about later perimenopausal stage or near the menopause, where we have more likely going to have unopposed estrogen, but at the same time, she is actually dropping her estrogen and her progesterone. Progesterone is lacking because of anovulation, but also her ovaries are not anymore producing, that amount of estrogen from the Graafian follicles. So here we have lower level of estrogen, and that's why we have little of bleeding, but I say that may last some time longer. In order to understand the endometrial pathology or causes of bleeding in these cases, whether they are ovulatory or in origin, let's show you here how a normal woman stop her period. If any woman is having a period and she has not secure these three mechanisms, she'll keep bleeding forever. But these three mechanisms are really what really stop the bleeding. First of all, when she starts to bleed, platelet aggregation comes in to control these sites of bleeding. Prostaglandin actually mediation, which is really we have in this, according to this arachidonic flow chart, which is you have the prostaglandin, and then through the prostaglandin synthase, either we're going to have the thromboxane and the F2 alpha, or you're going to have the E2. Now, the E2 is the vasodilators. Thromboxane and F2 alpha is the vasoconstrictor. So usually we have is during the luteal phase, we have a tendency to have more of those vasoconstrictive in order to have the stopping of the bleeding. And lastly, the tissue repair. Here we have either the epithelial or the vascular epithelial growth factors, which really control that repair. Imagine it has been looked at this point very clearly in some of the studies where they did hysteroscopy at the time of the menses, and they found there is simultaneous breakdown and buildup of the endometrium, which is really reflecting this kind of mechanism. So, with the ovulatory bleeding, here is reverse is happening. There is more vasodilation. That means of the F2 A2 rather than F2 alpha, and also there is blocking of the other factors. And so, we have here different medications that can be utilized in situations like this, where they have either the oral progestins, or you have also sometimes the intramuscular one. But what we need actually is to produce mid-cycle estradiol secretion. We need a prolonged progesterone activity leading to secure the secretory stages, and also we need thinning of the endometrium so that we reduce the amount of the bleeding. And this is how we've been including giving it either cyclic or in extended use. In conclusion, the menstrual disorders are major complex health predominating due to two major health concerns, the bleeding and the anemia. Don't forget about the anemia. It's women's awareness is so frail that half of the affected women do not seek medical care. Using the FIGO-AUB classification is an important prerequisite to manage AUB, and also one-stop approach is a simplified holistic practice for AUB management. AUBO is a common presentation of ovarian dysfunction resulting in an abnormal uterine endometrial shedding. Secure your diagnostic and rule out the structural causes of AUB with the help of tattoo to understand and treat AUBO. Thank you very much.
Thank you very much, Dr. Arab, for your excellent presentation.